Welcome to All in All.
Great to be diving in.
Today we're tackling something really common, affects millions actually, but maybe isn't always fully understood. Heartburn, acid reflux, and its more persistent cousin, GERD, gastroesophageal reflux disease.
That's right. We've gathered the source materials you sent over, and we're going to really unpack it. It's common, yes, but it can have a pretty big impact.
So our mission today is to get past just the burning feeling and pull out the key insights.
Yeah, look at where it comes from, why it matters so much to people's lives, potential risks, how our understanding has actually changed over time.
And importantly, what you, the listener, can practically do about it. We want to help you get really well informed. Might even uncover a few surprises.
Definitely. Should we start at the beginning? What is acid reflux?
Let's do it. So, at its core, it's when stomach acid goes the wrong way, back up into the esophagus.
And that stomach acid is powerful stuff. I mean, it has to be to break down food.
Right, but the esophagus, your food pipe, it just doesn't have that same kind of protective lining as the stomach. It's more delicate.
Exactly. And the thing that's supposed to stop this backflow is a really clever little muscle at the bottom of the esophagus. It's called the lower esophageal sphincter, or LES for short.
LES, okay, so it's like a valve.
Pretty much, yeah. A ring of muscle right where the esophagus meets the stomach. Its main job is to open up when you swallow, let food go down,
And then close up tight.
snap shut. Creates a barrier to keep everything in the stomach, especially that acid, from splashing back up. Now, it does open slightly for, boops or hiccups. That's normal.
Okay, so that's normal function. The problem starts when that valve, the LES, gets a bit weak or relaxes when it shouldn't.
That's the crux of it. When it doesn't close properly, acid can reflux, sneak back up into the esophagus.
And maybe you get that occasionally, right? After a big meal or something.
Happens to most people now and then.
Mm-hmm.
But when it's frequent, when it starts causing really disruptive symptoms or actual damage to the esophagus, that's when we start talking about GERD.
GERD. So it's more severe, more chronic?
Yeah, it points to a more significant issue with that LES function. Or maybe other things increasing pressure, like we'll get into.
Okay, so why? Why does this crucial valve malfunction? What are the main culprits the sources highlighted?
Well, there are quite a few, and often they work together. But one really big one, a sort of mechanical issue, is something called a hiatal hernia.
Ah, yes, I remember reading about that. Explain that a bit more.
Sure. Your diaphragm is that big muscle separating your chest from your abdomen, right?
Uh-huh.
The esophagus passes through an opening in the diaphragm to reach the stomach. A hiatal hernia is when the very top part of the stomach actually pushes up through that same opening into the chest cavity.
So part of the stomach is now above the diaphragm.
Exactly. And when that happens, it can kind of squeeze the esophagus, but critically, it often pulls that LES valve up too, so it's sitting above the diaphragm.
And why is that bad? Why does being above the diaphragm matter so much?
Because the diaphragm muscle itself actually provides some external support to the LES, helping it stay pinched closed. When the LES moves up, it loses that reinforcement.
Ah, I see. So it's easier for it to open up inappropriately.
Much easier. It can be a source of constant reflux. Like in Darlene's story from the sources, 50 years of discomfort traced back to a large hiatal hernia. Surgery eventually fixed it, but 50 years.
Wow. That's incredibly persistent. Shows how structural issues can be key. What else weakens the LES or increases reflux?
Another major factor is increased pressure inside the abdomen. Think about pregnancy.
Right, the baby takes up space.
A lot of space.
Yeah.
That growing uterus pushes everything upwards, including the stomach, increasing pressure. Plus, pregnancy hormones like relaxin, estrogen, progesterone, they tend to relax muscles throughout the body.
Including the LES.
Including the LES, so it's a double whammy.
Right.
Pressure and hormones.
Okay. And obesity. Similar mechanism.
Very similar. Extra weight, especially around the abdomen, creates chronic pressure pushing on the stomach. It makes reflux more likely and, interestingly, is also a risk factor for developing those hiatal hernias over time.
Ah, okay, so it's linked to hiatal hernias too.
Yes. And increased body fat can also influence hormone levels like estrogen, potentially adding to the effect.
It's not just passive weight then, it actively affects things.
It does. Then there's smoking. And this was interesting. It's not just smoking yourself, but secondhand smoke too.
Really? Secondhand smoke as well.
Yeah. Nicotine itself is known to relax the LES muscle directly.
Ugh.
But smoking can also make you cough more.
Which would force the LES open, right?
Repeatedly.
Yeah.
And that chronic coughing might even weaken the diaphragm muscles that are supposed to support the LES, potentially contributing to a hiatal hernia down the line.
I already thought of that connection.
And smoking also slows down how quickly your stomach empties and can even increase the amount of acid your stomach produces. So it hits from multiple angles.
Man, it really does. Okay, what about the obvious one, food and drink?
Ah, yes, diet and eating habits. Definitely key triggers for many people. Certain things are known to relax the LES. The usual suspects came up in the sources. Coffee,
Hmm?
even decaf,
Oh
unfortunately.
no, not the coffee.
I know. Also soda, tomatoes, alcohol, chocolate, peppermint, garlic, onions. Lots of common foods.
So comfort foods causing discomfort. Typical.
Can happen. And how you eat matters too. Overeating literally stretches the stomach, making it harder for the LES to close properly.
Makes sense.
Eating too fast, lying down too soon after eating, or having a big meal right before bed, all that works against gravity. Gravity normally helps keep stomach contents down where they belong.
Simple physics, really.
It is. And here's one people might overlook: medications. Common drugs taken for other conditions can sometimes trigger heartburn by relaxing the LES.
Like what kind of medications?
The sources mention things like benzodiazepines, certain sedatives, or anti-anxiety meds, calcium channel blockers used for high blood pressure, some types of antidepressants, specifically tricyclic ones, NSAIDs, common painkillers like aspirin, ibuprofen, theophylline for asthma, even hormone therapy.
Wow, that's a lot of common medications.
Yeah.
Really highlights you need to consider everything.
Absolutely, your whole health picture. And finally, there's the link with stress and anxiety. It's complex and maybe not fully understood yet.
How might stress play a role?
Well, the thinking is that anxiety might directly reduce the pressure in the LES, or it could cause muscle tension around the stomach, physically increasing pressure. Some theories suggest it might even ramp up acid production, and it can become a real vicious cycle. Having severe reflux that's hard to control is, itself, incredibly stressful and anxiety-provoking. Jessica's story really hit that home, feeling like a ball of acid, the anxiety being off the charts.
I can completely see that. Constant physical discomfort would absolutely affect your mental state. So, okay, we've got all these potential causes. What does it actually feel like? What are the symptoms?
The classic one everyone knows is that burning feeling in the chest. Heartburn. Often feels like it's moving up from your stomach towards your throat.
And it's often worse at certain times.
Yes, characteristically worse at night, or when you lie down again, losing that gravity assist. Also common after big meals, especially fatty ones, after bending over or after having alcohol or smoking.
The classic heartburn. But you said earlier it's not always just heartburn for GERD.
Exactly. Regurgitation is another very common one. That's the feeling of food or sour liquid washing back up into your throat or mouth. Not pleasant.
No.
You can also get upper belly pain or chest pain that isn't burning. Sometimes it can be quite severe. Remember Alex's story? His GERD pain was so bad, it felt exactly like a heart attack.
Yeah, that was scary. Really shows why you should never ignore chest pain.
Never. Always get it checked out. Other symptoms can include difficulty swallowing. The medical term is dysphagia, or feeling like there's a lump stuck in your throat even when there isn't. That's called globus sensation.
Okay. What about babies? We hear about spit up all the time. Is that GERD?
That's a great question. Simple spitting up is super common and usually totally normal for infants. It might have a bit of acid, sure, but it doesn't usually cause them pain or problems gaining weight.
So GERD in babies is different.
Yes, it's more severe. It causes obvious distress. Maybe they cry excessively around feeding times, have trouble sleeping flat, refuse to eat, or aren't gaining weight well. They might have small, painful-seeming vomiting episodes, wheezing, hoarseness, even bad breath. It's more than just effortless spit up.
So it's about the impact on the baby's well-being.
Exactly. More likely in preemies or babies with other esophageal issues.
Got it. And what if the acid travels even higher past the esophagus?
Then you're talking about laryngopharyngeal reflux, or LPR, sometimes called silent reflux.
Silent reflux. Why silent?
Because often, people with LPR don't get that classic heartburn feeling in their chest. The acid travels all the way up to the throat, the voice box, the larynx, sometimes even into the airways.
So the symptoms are different.
Yeah, they're typically centered higher up, things like chronic hoarseness, laryngitis, constantly feeling like you need to clear your throat, a persistent tickle or coating sensation back there.
Like AJ's story described, losing her voice and that coating feeling.
Exactly like that. Sometimes people can even develop non-cancerous growths on their vocal cords because of the irritation.
So LPR can be tricky because you might not have the main symptom people associate with reflux. Okay, let's zoom out. Why does all this matter? Beyond the day-to-day discomfort, what's the bigger picture significance of chronic GERD?
Well, it really boils down to quality of life impact and the potential for serious long-term complications. Occasional heartburn is annoying, sure. Chronic GED can really drag you down.
How's
Studies mentioned in the sources use questionnaires, like the GERD-HR-QOL, specifically designed to measure this. They consistently show GERD impacts, sleep, eating enjoyment, social activities, work, pretty much all aspects of life. And the good news is, effective treatment shows significant improvements on these scores.
So it genuinely impacts how you function day to day.
Absolutely.
Yeah.
And there's an economic cost, too. That European observational study was quite telling. It found GERD leads to actual time off work absenteeism.
How much time?
Well, it varied by country, but in Germany, for instance, it was up to about 3.2 hours per week lost. But even bigger was presenteeism.
Presenteeism, meaning you're at work but not fully productive.
Exactly. You're there, but the symptoms are distracting you, slowing you down. In Norway, that study found presenteeism accounted for up to an additional 6.7 hours of lost productivity per week compared to healthy workers. That adds up.
That's a huge chunk of time and efficiency loss. It affects personal life too, presumably.
Well, yeah. The studies noted productivity losses in just regular daily life activities as well, sometimes up to a 26% reduction. And then there's sleep. The link between GERD, especially nighttime reflux, and sleep disruption is really well established. Waking up choking or burning, it fragments your sleep.
Right. Poor sleep affects everything.
It does. And we circle back to that link with anxiety and stress. As we said, it can be reciprocal, the constant symptoms, the worry about complications. It can fuel anxiety, which then might make the reflux worse. A really tough cycle for people caught in it.
So it's a condition that can chip away at your physical health, your ability to function, your sleep, and your mental peace. That brings us to the physical damage. What happens if that acid exposure continues long term? What are the actual complications?
This is really important. That esophageal lining just isn't built for acid, unlike the stomach. Chronic exposure leads to damage. The most common complication is esophagitis.
Which is just inflammation of the esophagus.
Exactly. Inflammation of the lining. And that causes chronic pain. If it's persistent and severe, you can develop ulcers, actual sores in the lining, deeper than just surface irritation or erosions.
Can those ulcers bleed?
They can, yes. And over time, all that chronic inflammation and injury leads to scarring. It can also, worryingly, lead to changes in the cells themselves, becoming precancerous.
Precancerous. That sounds serious.
It is a major concern down the line. The severity of esophagitis is often graded based on how widespread the damage, the erosions are. Are they just isolated spots? Are they running together, confluent? Or do they go all the way around the circumference of the esophagus? Circumferential is the most severe.
Okay. And you mentioned esophageal ulcers are different from stomach ulcers.
Yeah, an interesting point from the sources. Stomach and duodenal ulcers are very often linked to infection with H. pylori bacteria. But esophageal ulcers, those are typically caused directly by the damage from acid reflux itself.
Got it. So inflammation, ulcers, scarring. What happens when that scar tissue builds up?
That scarring can cause the esophagus to narrow. It's called an esophageal stricture.
Narrowing, so it makes it hard to swallow.
Very hard. Food and even liquids can get stuck. It significantly impacts eating, drinking, nutrition. It's a serious complication.
How common are strictures?
Less common than just inflammation than esophagitis, but GERD is actually the cause of most strictures found in the lower esophagus, something like 70–80% of them. They tend to become more common as people age and seem to affect white men more often.
Okay.
And here's that counterintuitive thing again. Sometimes, as a stricture gets tighter and narrower, the person might actually experience less severe heartburn.
Because less stuff can reflux back up through the narrowed opening.
Precisely. So the symptom might seem to improve, even as the underlying problem, the narrowing, is getting worse.
Wow. That's tricky. Definitely underscores why difficulty swallowing needs attention, even if heartburn is better.
Absolutely.
And the precancerous changes you mentioned, what's that called?
That condition is Barrett's esophagus. It's where the normal cells lining the lower part of the esophagus actually change and start to resemble the cells that line your intestines.
Why do they change?
It's thought to be the result of long-term exposure to stomach acid and possibly bile salts refluxing up as well. Barrett's itself isn't cancer, but it significantly increases the risk of developing a specific type of esophageal cancer called esophageal adenocarcinoma.
Adenocarcinoma. And the rates of that are increasing.
Yes, unfortunately. Particularly among white males, the incidence has risen quite rapidly over recent decades.
So if you have GERD, do you automatically get Barrett's? Is it a definite path to cancer?
No, absolutely not. It's really important to stress that. While severe, long-standing GERD is a risk factor for Barrett's, many people with severe GERD never develop it. And the vast majority of people who do have Barrett's esophagus will never actually develop esophageal cancer. It increases the risk, but it's not a guarantee by any means.
Okay, that's a crucial clarification. Risk factor, not destiny.
Exactly. And interestingly, the sources noted that it's not always clear that people with Barrett's have massively higher acid levels than people with just esophagitis. It suggests other factors, perhaps like those bile salts mixed in with the acid, might be really important in driving those specific cell changes.
So it's more complex than just pure acid damage for Barrett's.
Seems likely.
Were other risk factors for esophageal cancer mentioned, besides GERD and Barrett's?
Yeah, a couple of others. Achalasia, which is a disorder affecting the muscles that move food down the esophagus that carries a significantly increased risk, often many years after diagnosis. And a very rare genetic condition called tylosis, linked to a gene called RHBDF2, causes skin problems and growths in the esophagus with a very high cancer risk.
Okay.
But for most esophageal cancers, it's thought that changes in many different genes are usually involved, not just one single cause.
Right. And what about complications specifically from LPR, the throat reflux?
Well, that acid irritating the delicate tissues of the throat and voice box can cause chronic swelling, that persistent hoarseness we talked about, maybe even those non-cancerous vocal cord polyps or growths. And there's the risk of aspirating tiny amounts of acid into the airways.
Aspirating, meaning breathing it in. How does that affect the lungs?
It can really irritate the bronchial tubes. If you already have asthma, reflux, especially LPR, can be a major trigger, making your asthma worse or harder to control.
Can it cause breathing problems even if you don't have asthma?
Yes, sometimes it can cause asthma-like symptoms, wheezing, chronic cough, just from the irritation of the airways by the refluxed acid.
So it seems like what starts as simple heartburn can, if it's chronic GERD and left unmanaged, lead to a whole cascade of issues, from swallowing problems and tissue changes to cancer risk and even respiratory problems. It's quite a spectrum.
It really is.
How has our understanding of all this changed? You mentioned progress over the last 40 years.
Yeah, there's been a huge evolution.
Yeah.
We've gotten much better at actually defining GERD as a distinct condition, not just occasional indigestion. There's a much greater recognition now of its impact on quality of life, and also the significant economic costs associated with lost productivity and healthcare use.
So taking it more seriously as a disease entity.
Definitely. And our understanding of the underlying mechanisms, the pathophysiology, has advanced too. Things like pinpointing the role of those transient LES relaxations times, the valve relaxes inappropriately, not related to swallowing, and concepts like the acid pocket.
Acid pocket? What's that?
It's this layer of highly acidic fluid that can form at the very top of the stomach contents right after eating, making it more likely that any reflux will be particularly acidic and damaging.
Ah, interesting. And diagnostic tools have improved too.
Hugely. We've gone from basic observation to much more sophisticated tests. Wireless pH monitoring capsules can measure acid exposure over 24 or 48 hours while you go about your day. Impedance testing can detect reflux that isn't acidic, like gas or weakly acidic fluid. High-resolution manometry gives incredibly detailed maps of how the esophageal muscles are working.
So we can measure reflux better and see how the esophagus is functioning.
And endoscopy, looking inside with a camera, has become much higher resolution, allowing doctors to see inflammation, erosions, Barrett's changes much more clearly.
Okay. What about treatments? How have they evolved?
Well, pharmacologically, the big revolution was the development of proton pump inhibitors, PPIs.
Like omeprazole, sumpirasole, those kinds of drugs?
Exactly. They are extremely effective at shutting down acid production in the stomach. They quickly became the first-line treatment for many people, especially those with visible damage, esophagitis.
A game changer, then.
For many, yes. We also have the H2 blockers, like famotidine, which work differently to reduce acid, and newer drugs called potassium-competitive acid blockers, or PCABs, are emerging too.
But you mentioned PPIs aren't perfect for everyone.
Right. An important point from the sources is that while they're great for healing esophagitis, they seem to be less consistently effective for people whose main issue is symptoms without visible damage. That's called non-erosive reflux disease, or NERD. And there's ongoing research and discussion about the potential long-term effects and safety of being on PPIs for many, many years.
So powerful drugs, but still questions and areas for improvement.
Absolutely. And it's worth remembering the path to new drugs isn't always straight. The sources mentioned some promising therapies that ultimately failed in trials or had to be withdrawn due to side effects. It's a complex area to treat.
What about non-drug approaches? Surgery.
Yes, surgical and endoscopic techniques have also advanced significantly. The classic surgery is the Nissen fundoplication, usually done laparoscopically now, where the top part of the stomach is wrapped around the lower esophagus to reinforce the LES.
To tighten that valve, essentially.
Right. And newer options include things like magnetic sphincter augmentation, basically implanting a ring of magnetic beads around the LES to help keep it closed. Darlene's successful surgery for her massive hiatal hernia really speaks to how effective these procedures can be for the right patient.
It's good there are more options now. Anything surprising about who gets GERD? Any demographic shifts?
Well, one interesting note was about ethnicity. Historically, esophagitis, the inflammation, was thought to be much more common in white populations compared to, say, Asian populations. But some newer data suggests it might actually be underestimated or perhaps increasing in Asian countries. So we need to keep studying it across diverse groups.
That's important. Okay, let's bring this all together. For someone listening who experiences these symptoms, what's the practical takeaway? What can they actually do?
I think the biggest message is that for most people, GERD is manageable. You don't just have to suffer through it. And the starting point, almost always, is lifestyle adjustments.
Back to the habits we discussed: diet, smoking, weight.
Exactly. Changing what you eat, identifying and avoiding your personal trigger foods. And changing how you eat smaller meals. Not eating too late, giving food time to digest before lying down, eating slowly. Losing excess weight can make a huge difference. Quitting smoking and reducing alcohol intake are fundamental too.
Taking control of those daily factors first.
It's foundational. Then there are medications. For mild, occasional symptoms, over-the-counter options are often the first step. Antacids can give quick, temporary relief by neutralizing the acid that's already there.
Like Tums or Rolaids.
Yeah, things like that. Then you have the low-dose H2 blockers available over-the-counter, like famotidine, Pepcid, or cimetidine, Tagamet. They work by reducing the amount of acid the stomach produces.
So antacids neutralize, H2 blockers reduce production.
Generally, yes. H2 blockers take a bit longer to work, but the effect lasts longer. For more frequent or severe symptoms, a doctor might prescribe stronger doses of H2 blockers. Or, more commonly, they'll go to the PPIs we talked about.
The omeprazoles, lansoprazole.
Right. They're very potent acid suppressors, often the first choice for healing esophagitis. But again, remember, they might not fully resolve symptoms for everyone, especially in non-erosive disease. And long-term use is something to discuss with your doctor.
Okay. Any other medication types? You mentioned alginates earlier.
Yes, alginates are interesting because they work mechanically. You take them after eating, and they react with stomach acid to form this sort of foamy raft that floats on top of the stomach contents.
The physical barrier.
Exactly. It acts like a lid, physically blocking reflux from happening. They're often used for self-treatment and sometimes combined with antacids.
That's a completely different mechanism. Clever.
It is. And speaking of different approaches, that study looking at a natural product was quite interesting. It combined that alginate KB carbonate raft idea with extracts from prickly pear cactus, Opuntia, and olive tree leaves, Olea.
Prickly pear and olive leaves. What did they find?
They found this combination significantly reduced symptoms like heartburn and regurgitation, and improved quality of life scores in people with moderate GERD compared to just the alginate carbonate.
Why would the plant extracts help?
The thinking was that these extracts might have protective effects on the esophageal lining itself, possibly due to antioxidant or anti-inflammatory properties, complementing the physical barrier from the alginate. It points towards exploring ways to support the body's own defenses.
Fascinating. So multiple angles of attack potentially. What if lifestyle and meds aren't enough?
Then surgery becomes a real consideration, especially for chronic, severe GERD that's really impacting life, or if there's a significant structural problem like that hiatal hernia.
Right.
Procedures like the Nissen fundoplication can be very effective long-term solutions for selected patients.
So it sounds like there's a whole toolbox: lifestyle, OTC meds, prescriptions, natural approaches, surgery.
There is, which leads to maybe the most crucial practical point from all the sources. If you have heartburn or reflux symptoms frequently, if they're bothering you, waking you up, interfere with your life, or if you have any alarm symptoms like trouble swallowing, unexplained weight loss, vomiting, chest pain, don't just ignore it or keep self-treating indefinitely.
Talk to a doctor.
Please talk to a healthcare provider. They can figure out what's really going on, make sure it's not something else, and help you navigate all these options to find the best strategy for you.
Excellent advice. Definitely not something to just put up with, given everything we've discussed.
Absolutely not.
Okay, as we wrap up this deep dive, reflecting on all this information from the sources, what's one final, maybe provocative thought you'd leave our listeners with?
I think it's reflecting on how managing a chronic condition like GERD really forces you to confront the connections between different parts of your life. It's not just about popping a pill. It often involves this intricate navigation between your diet, your daily habits, maybe medications with their own effects, the physical mechanics of your body, and even your mental state, that stress and anxiety component we talked about.
Yeah.
It really highlights how deeply interconnected our physical and our psychological well-being truly are. Managing one often requires paying close attention to the other.
That's a powerful point. That complex interplay is key. Thank you for unpacking all of that for us today.
My pleasure. It was a great discussion.
Thanks for listening to All in All.